Hi everyone, and welcome to the 8th international webinar sponsored by the World Federation of Athletic Training and Therapy. My name is Stavros Doukas. I'm committee member of the Research and Education Committee of the WFATT and president of the Greek Association of Sports Therapy and Rehabilitation, and will be your host today for today's presentation. It's important to mention that we're hosting this webinar alongside Basrat, so we just want to send thanks to Basrat and Oliver for helping us host this webinar today. Now, once again, it's so lovely to see so many people from all over the world attending this webinar we've put on today, and we're also excited for having our special guest speakers to present their topics. So today's webinar comprises two presentations. The first one, Dr. Nikos Malliaropoulos will be presenting on clinical classification of hamstring tears, and then Dr. Mourad Ghrairi will be presenting on return to play following anterior cruciate ligament repair. Dr. Malliaropoulos and Dr. Ghrairi, thank you both for being with us today to share your knowledge and expertise to hundreds of healthcare professionals here on today's webinar. Now, before we go on to the presentation, there's a few housekeeping notes. First of all, the session will be recorded and uploaded on the World Federation website for future reference. Each presentation will be approximately 30 minutes, followed by 20 to 30 minutes of questions. And then the questions can be submitted in writing during the presentation by using the Q&A feature. And then we're going to go through them after the end of both presentations. So now I'm pleased to introduce now Dr. Nikos Malliaropoulos, who is a sports and exercise medicine consultant physician at Barts End London, senior clinical lecturer at Queen Mary University of London in the Center of Sports and Exercise Medicine, medical director of the Sports Injuries Clinic of the Track and Field, and Secretary General of the European College of Sports and Exercise Physicians. So I want to welcome now Dr. Malliaropoulos to the first presentation today. We all look forward to this very interesting presentation, and I will now ask him to share his slides with us. Dr. Malliaropoulos, we are ready to start.
Thank you, Stavros. Thank you, Stavros, for the introduction and for having us at this very interesting international webinar. It's my pleasure being with you and sharing our knowledge on sports injuries. So I think you can see my slides. It's really fine.
Yes, we can.
Perfect. So as it says, the program, we will try to analyze the diagnosis and classification of hamstring injuries, the injury mechanics, reoccurrence, prevention, and different types of hamstring injuries. I think diagnosis, classification, and grading of such a common injury is really important. It is fundamental for rehabilitation and for the athletes to return to play. So thank you for the introduction. I have been in the last 35 years working as a full-time sports and exercise medicine physician. And muscle injuries were one of the most common problems and injuries in athletes in all sports. So muscle injuries are very common in sports, but very often today they are misunderstood and inadequately treated. And muscle injuries can be between 10 to 30% of all sports injuries. From our epidemiological data, in the last, as you can see, 30 years in track and field, in elite track and field athletes, hamstring injuries was representing 20% of all sports injuries. And if we add that to acute injuries, then it was about half of all acute injuries in track and field. So it's a huge amount, and very often it's a nightmare for athletes and coaches. analyzing our data further, we saw something which is logical, that sprinters was suffered by more, followed by jumpers, and then by combined events, throwers, middle distance. So sprinting or high acceleration activities in sports predisposes to more injuries. And then we saw that the distribution between the right and the left was approximately the same. And then most commonly the injuries are happening on the upper third, followed by the middle, and then by the lower third of hamstring muscles. The majority of the injuries, 75% was at biceps femoris. It was on the lateral muscle group. So that's really interesting information in terms of developing our prevention programs. Also, we saw that from other studies, there was a distribution between sex. 64% males were suffered more from hamstring injuries. So hamstring injuries, it's really a problem in sports medicine. And we have to remember for approaching, treating, and rehabilitating hamstring injuries, we have to remember the basics. That hamstring injuries, they act as hip extensors, they act as knee flexors, and also they act as external and internal and as external rotators of the hip. Also, we have to notice that they receive dual innervation. So they receive innervation from the tibial portion of the sciatic nerve and the common peroneal nerve. So hamstrings, they're receiving two different inputs from in terms of innervation. And this, in some cases, might be a predisposing factor. So even though sports medicine, sports rehabilitation has been improved in the last decade, it was a very interesting study showing that instead of this progress in terms of our knowledge, hamstring injuries keep increasing 4% annually. And that's really worrying both the physicians, the medical teams, coaches, and athletes. So soft tissue injuries, and particularly hamstring injuries, to my knowledge, to my experience, it's still today a challenge and can be very often a clinical problem for the medical team, for the coaches, for the athletes. And just reminding the anatomy of the area, so starts from the ischial tuberosity, and then you can see semitendinosus, semimembranosus in the medial side, and then biceps femoris on the lateral side. And that's how it looks on an MRI scan. So on an MRI scan, that's the ischial tuberosity there. That's the tendon, the central tendon of the hamstring group, which goes all the way down. And then we have to notice here that that's the central tendon, that's the ischial tuberosity, that's the ischial tendon, goes all the way down, and in very few millimeters apart is the sciatic nerve. So very often, injuries to this area, tendon or muscle tendon junction, can affect the nerve. So we have to be very careful in terms of diagnosis, in terms of the location, but of course in terms of re-injuries, because we know re-injuries, it's a great factor to develop scar tissue. And then if this scar tissue development potentially can affect the sciatic nerve. And that's on a cross-sectional area. So you can see biceps femoris there, short head, biceps femoris, long head, and then semitendinosus and semimembranosus. So we published a lot of our research, and during one of our papers, they asked us, can you please give us a definition of a hamstring injury? And the question is so simple, and we struggled to answer what we define as a hamstring injury. So majority of hamstring injuries are acute, so that's a hamstring injury. Majority of them, 90%, are non-contact, location posterior thigh muscle injury. All the athletes are reporting an incidence either during training or competition, can be structural or functional, and I'll come to that. All of them, they have to present with a musculoskeletal triad. I will explain that later. And always there must be a time loss. So that's our definition for a hamstring injury. And this was published at BJSM 2015. So hamstring injuries, all of them must be acute. Majority are non-contact. Location posterior thigh muscle injuries. All the athletes are reporting an incidence, occurs during training or competition, can be either structural or functional. All of them, they are presenting with a musculoskeletal triad, and they are leading to a time loss. So how we will define, diagnose, classify, grade such a common injury? So many attempts has been to classify hamstring injuries from different point of views. So one point of view was the anatomical location plus imaging. One of our very close colleagues, the radiologist Otto Chan, and a very close friend and colleague, Professor Nicola Mafuli, they published 2012 a proposal of clinical classification, of a hamstring classification. So they divided, depending on the location, on the proximal muscle tendon junction, muscle, and the distal tendon junction. So depending on the location, on the MRI, it was proposed that kind of classification. It was really a good attempt, mentioning the location of the injury, but again, in terms of clinical terms, how we can follow that kind of injuries during rehabilitation. What does that really clinical means? If it's on the muscle belly, if it's on the distal muscle tendon junction, or on the proximal muscle tendon junction? And then, what about injuries, as we can see later on, that the MRI scan or the ultrasound scan is absolutely without any findings? What about those injuries? So that was the first attempt. And then it was another attempt from our Barcelona colleagues, Javier Valle and Ricardo Pruna, bringing in again the conception of the tendon injury, muscle tendon junction, and then the distal muscle belly and the tendon running the muscle belly, so the central tendon. So that was in 2014. And again, nowadays we know that if the central tendon is involved, then that makes the prognosis more difficult. And we saw that in different sports activities, hamstring injury occurs. So hamstring injury can occur during stretching, and that affects mainly gymnasts, dancers, taekwondo players. When a footballer is stretching out, can receive a hamstring injury. And also hamstring injuries can occur in different sports, running, sprinting, football players when they are sprinting. So we have an injury of the hamstrings, but with a different mechanism. And that makes really a difference, and we have to take it into consideration. So having this knowledge, nowadays, we divide hamstring injuries depending on the mechanism on stretching type injuries, which mainly or usually affects the medial part of hamstrings, and then the high speed or the contracting type injuries during sprinting, which mainly affect biceps femoris. So knowing the mechanism of the injury, we can predict the location, which muscle group is affected, and also it's very useful for rehabilitation. Imaging was also used in terms of diagnosis and classification. So MRI was used, and the first study was published was on 14 patients. And then the British athletics, they brought in a classification based on imaging and on anatomical findings on imaging, grading the injuries on 4 grades. But in all those classifications, either imaging or location, it was always the same question coming from the athletes. When I will be back? Could those classifications predict the time to return to play? That's the burning question from athletes and coaches. And you can see on imaging, on an MRI scan, that's the area of the injury. And here, beautifully, you can see that the muscle injury was around the central muscle tendon. So depending on the extent of the injury, it was classified in 4 grades. So MRI or imaging really helps. So there was a very good study from Jan Ekstrand saying that maybe 70% of hamstring injuries in professional football there was no any signs or findings on an MRI scan. And I'm coming back. Previously, I said about functional and structural injuries. So a structural injury, or on a structural injury, you can have findings on an MRI scan. In a functional injury, symptoms are there, but no findings on imaging. And there was a question about the usefulness of an MRI scan. So MRI scan absolutely helps, but we cannot rely only on imaging in terms of diagnosis. And it's very useful when we have to decide about surgical or conservative approach. So yes, imaging, and particularly MRI, is very helpful. It's a helpful tool, but we cannot base on MRI findings or in imaging findings to classify and diagnose an injury. And then, of course, ultrasound was used. It was Petrun's 2002, so already around 20 years ago, that muscle injuries were graded in 4 grades. Grade 0, absolutely no findings. Grade 1, grade 2, and grade 3. So we saw the classification for, depending on the location, muscle tendon injection, muscle, free muscle tendon, distal muscle tendon junction. We saw about imaging. What about clinical classifications? And the majority of the medical personnel or the health providers are clinicians. They are not radiologists, they are not anatomists, they are clinicians. So what about the clinical findings? So it was a lot of attempts to classify clinically muscle and hamstring injuries. It was an old classification, as you can see, 1969, grading grade 1, grade 2, grade 3, mild, moderate, or severe injuries, but without any clinical usefulness. Time to walk pain-free after an injury, we can take it into consideration, but nothing could answer the burning question, when I'll be back. So having the pressure from elite athletes in track and field, 2010, we published the clinical classification of hamstring injuries. And we are based our clinical classification on active range of motion, measuring the range of motion of hamstring injuries, on ultrasound findings, and we are recording the time to full rehabilitation from day 1. Musculoskeletal triad must always be there. Musculoskeletal triad, pain on palpation, pain on isometric contraction, pain on passive flexion of the hip. So all those must be present in terms of the clinical evaluation. Active range of motion, measuring range of motion, active range of motion and not passive, measuring on both sides. And logically, we can presume that the injured side has a reduced active range of motion. We took into consideration any findings on the ultrasound scan, and we calculate the time to full rehabilitation. And what we saw, after analyzing all the data, we grade we grade the injuries in 4 grades: grade 1, grade 2, grade 3, grade 4. So grade 1 injuries had a reduction or a difference in active range of motion between the injured and the healthy side of 10 degrees. Grade 2 injuries, active range of motion difference up to 20 degrees. Grade 3 injuries, reduction of active range of motion up to 30 degrees. Grade 4 injuries, more than 30 degrees. All of them, grade 3 and grade 4, they had findings on ultrasound scan. No findings on grade 1 injuries. Some findings, some edema on grade 2 injuries. So we proposed that for grade 1 injuries, depending on the clinical findings and active range of motion, we do not need any imaging. Grade 2 injuries, ultrasound scan can be absolutely fine. Grade 3 and grade 4 injuries needs an MRI scan. So early on, in the first 48 hours, estimating active range of motion, we could predict which imaging tool should be used, and also we could predict the time to full rehabilitation. Later on, 2015, the Barcelona group came with a further classification of hamstring injuries, taking into consideration the mechanism of the injury, which I said previously, really important, and taking into consideration re-injuries. And that was the proposal of their classification: mechanism, location, grading, and then depending on re-injuries. At the same time, 2014, we thought that we haven't any functional tool in terms of following the rehabilitation time. So we developed a functional assessment scale for acute hamstring injuries, which already has been translated in more than 6 different languages all over the world. And this is very useful to monitor rehabilitation and return to play athletes with hamstring injuries. So, just to summarize the first part of our lecture, diagnose and classify hamstring injuries. The re-injury history plays an important role. Mechanism of the injury, contracting or stretching type, it is important. The anatomical location, again, plays an important role. The clinical classification, measuring active range of motion and classifying the injury in 4 grades. And imaging also must be taken into consideration. So a diagnosis of a hamstring injury, communicating between a health professional, must look like first time, non-contact, contracting type or stretching type, biceps femoris or semitendinosus, muscle tendon junction, grade 1, with imaging or with no imaging findings. So that's the diagnosis that give us the opportunity to communicate with our health professional colleagues, define early on and diagnose the injury, and then based on this, we can develop and we can plan for our treatment and rehabilitation. Always we have to take care and to consider differential diagnosis. Very often, pain or symptoms on the posterior thigh muscle injuries can be regarded as a referral pain. As I said, we have to keep in mind the definition of a hamstring injury. So all the elements of the hamstring definition injury must be there. What about re-injuries? Re-injuries, if an injury is a nightmare, re-injuries is even worse. And hamstring injuries has a tendency to reoccur and can be up to 30%. Why? Most of the time, it is because of the diagnosis and poor rehabilitation. So, definition of an early hamstring re-injury is a re-injury within 2 months, and a late hamstring re-injury can be between 3 to 12 months. Why? There's a high accuracy because of early return, poor diagnosis, poor rehabilitation programs. And you can see on the MRI scan, so remember when we saw the healthy hamstrings group, and you can see there, that's the healthy and the normal, and you can see this area, all this white area, which is scar tissue, of a repetitive hamstring injury at biceps femoris. And also there, that's the central tendon, and you can see there all the scar tissue. And remember, very close, it's the ischial nerve. So, as a feedback, we published a paper at the American Journal of Sports Medicine about re-injuries, and we saw, because very often we are talking about re-injuries, but again, with grade, all the injuries reoccur with the same frequency. We saw that that was not true. Grade 3 and grade 4 injuries, it had very, very low accuracy, even though there were serious injuries. Why? Because they accepted that the time to full rehabilitation, they needed more time. So the accuracy rate was lower. So key points.
Dr. Malliaropoulos, just a couple of
minutes,
5 minutes.
All right, thank you. Thank you, Stavros. So key points, clinical classification, really important. So estimate active range of motion early on within 48 hours from the injury. Location, it's really important because it's different if there is a muscle belly injury or the injury involves the central tendon. Ultrasound nowadays in clinical, for clinicians, it's like a stethoscope. I'm always using the ultrasound scan and I'm scanning every single patient. So it helps to diagnosis, it helps to monitor full-time during treatment or during rehabilitation. MRI is a gold standard. We are not based totally on MRI to diagnose the hamstring injuries, but it's a very helpful tool. Assessment for hamstring injuries, in our hands, very useful in terms of return to play. Treatment must be planned and based on clinical imaging, on imaging diagnosis, mechanism of the injury, location, anatomic location. If you would like to know more, then join us in Athens, November 2021. It will be a great congress after that difficult time with the pandemic all over the world, and hopefully we will meet there in person. Thank you very much for having me at this webinar.
Dr. Malliaropoulos, thank you. Thank you so much for your presentation. That was really, really interesting and at the same time informative. I'm pretty sure we're going to have a really, really productive discussion following the end of both presentations in the end of this webinar. And I think we close this presentation in such a way that we can now move smoothly to the second presentation for the day by Dr. Ghrairi. Dr. Mourad Ghrairi is a sports and exercise medicine consultant physician. He's the FIFA Chief Medical Officer at FIFA Medical Center of Excellence in Dubai, Medical Officer at the Asian Football Confederation, Chair of the European College of Sports and Exercise Physicians. Dr. Ghrairi, thank you for being with us today, and we all look forward to your presentation on return to play after ACL.
Thank you so much, dear Stavros, for this invitation. I'm very happy to be with you today, and it's a pleasure to share with you the experience of FIFA Medical Center of Excellence Dubai in terms of return to sport in athletes with ACL reconstruction. So, first of all, if we can just talk about this kind of introduction. So the surgery after an ACL injury is to have a knee stable, but is it enough? This is the question. After that, the rehabilitation is to have the normal function, but when it comes to athletes, there is a very important step between the rehabilitation and return to sport, what we call the re-athletization. And the goal of re-athletization that will get an athlete with physical and mental readiness. If we go through the international literature, we can say that we can find a lot of articles and bibliography related to different matters related to ACL injury and ACL surgery, rehabilitation, and return to sport. And the last decade, we can found like around 5,000 articles related to the surgery of the ACL. Fewer articles for rehabilitation and few articles regarding the return to play. And we can say that the return to sport or return to play is poorly investigated, poorly described, and the most important thing that we couldn't find a clear consensus in the literature. And the main question that if this ACL return to play ACL protocol after ACL reconstruction, if it is a protocol based on criteria or based on the time. And again, the literature we cannot find a clear answer, but we can say that most of the articles go to the current concept of the different progression of different phases based on many criteria. And we have to know exactly what we mean by return to sport. There is a little bit confusion when we talk about return to sport. If we go to look at the real definition, we have to know or to differentiate between return to normal training with the group in case of an injured player practicing collective sports like soccer, football, handball, basketball, or if it is a return to the competition, the games, the matches, or it's the return to pre-injury level. And this is a bit tricky question. So when we talk about the progression of many phases after surgery, rehabilitation, re-athletization, training, competition, definitely it will be based on a lot of criteria, but we can define three major kinds of criteria. First of all, it's a medical criteria, then it's a performance criteria, and finally, sports criteria. So to progress from rehabilitation to reathletization phase, it's mainly medical criteria. From reathletization phase to training with the group, it will be medical plus performance criteria, but we cannot decide the return to the competition without including some sports criteria that we will describe later on. So the medical criteria are very simple, very easy. The knee should be stable, free of symptoms. Pain is mainly pain and effusion. There shouldn't be any kind of pain and effusion. Quadriceps contraction, the third criteria, and the last criteria, the last medical criteria, should be a full range of motion. So before allowing the player to go inside the gym to start the rehabilitation program, so we have to satisfy these 4 criteria. So from the phase of protection of the graft to the phase when we will start the strengthening, we should mandatory satisfy these 4 criteria. Then, if we will go to the next phase, reathletization, so then we will include some performance criteria and sports criteria. So, and the performance criteria are mainly the control of the gait, measurement of the muscle strength and the ratio hamstring quadriceps, the measurement of the neuromuscular coordination, and the measurement of the explosive leg power, then the mental readiness. So all these performance criteria, we need to know exactly, we need in other devices. It's not only clinical assessment. It's not possible to do that only based on the clinical assessment. Previously, like 20 years ago, it was based on the experience of the trainers and physiotherapists and the doctors, but now we can have quantifiable, measurable parameters to assess those performance criteria. When it comes to the sports criteria, is especially the measurement of the general fitness readiness and the quantification of the sports-specific skills. So we need, for example, first criteria of the gait, we need a tool like a walker view. Yes. I think I'm facing, sorry, I'm facing, yeah, it should be okay now. So this is the walker view. Gate. Then to assess the muscle strength and the ratio hamstring quadriceps, we will use usually or
I think we're experiencing some issues.
Then the neuromuscular coordination.
Sorry, Dr. Ghrairi, we had some issues with the connection, so the videos were not. We couldn't able to watch all of the videos, and also it interacts and interferes with the connection of your speech. So we lost you for a couple of minutes, but now we have you back.
So shall I start back my videos?
I think we can try once more. Yes, I think we can try once more and see if that works. If
okay.
not, we will need to, unfortunately, to go along with videos.
So this is the first video when we can see the analysis, gait analysis with the device Walker view. So let me know if it turns or not. Is it okay?
We can still see some of the parts of the videos, but still we've got some connection problems for sure there. There is no
okay, so
play of the video.
So basically, maybe it's not easy to get the video with sometimes with the Zoom.
Yeah, absolutely.
And this is the last video. How to the then the last performance criteria is to assess the mental readiness. Is it on an ACL responsive of the anterior cruciate ligament to return to sport, psychological readiness to return to sport with IPRPS scales, and the last type of criteria, the sports criteria, to measure the readiness. The fitness readiness based on wearable technology and the assessment of the VO2 max. So the performance criteria to jump from the rehabilitation phase to re-athletization phase, we cannot allow to the injured players such progression without getting satisfied 50% less load difference of the normal gait, and the quadriceps strength deficit shouldn't exceed 30% comparative to other side, and the mental confidence index at least 50%. Sports criteria, the fitness should be at least 50% of the VO2 max. To allow the player to go to the normal training with the group in case he practices collective sports, the normal gait and load difference should be less than 50%. The quadriceps strength deficit based on the isokinetic assessment, less than 50%. The contact time difference of the speed court neuromuscular coordination, less than 10%. And the normal landing of the hop test, less than 10% of the jump distance, and mental readiness is around 70%. Sports criteria, the fitness should increase to around 75% of the VO2 max, and he have to be able to practice without any kind of complain some specific sports skills like plyometric exercises, acceleration, deceleration, sprints, jump, landing, change of direction, passes with ball, shoot, crosses, dribbling, and especially on the field, the 1-against-1 exercises should be really done successfully. Sorry. Then, how we will allow to our injured player, to reach the normal training and then the competition. So the performance criteria should be almost normal. All indicators should be near the normal, and especially with the mental readiness test around 90%. Then the fitness should be near 90%. And when it comes to the sport-specific skills, the player should be able to practice a full training with the group at least 4 weeks. Then it should be able to go gradually to 3 or 4 friendly games, like he started the second at the end of the game, 20-30 minutes, then a full halftime, then 60 minutes, then full game. We never allow to the player to go to the full game, normal game from the beginning, and everything should be gradually. But the main question remains when we can predict that the player will be able to perform with his pre-injury level. This is not easy at all to predict because there is many factors, mental, technical factors, his relation with his coach, his management, media environment, how he will manage the stress. For example, I can say that one player like Alessandro Del Piero, when he did his ACL injury, he came back to his pre-injury level like 14 or 16 months after surgery, for example. Also, we have to be very, very careful in this period to prevent re-injury. It's very important, and it's the responsibility of the coaching and medical staff to keep the player out as much as we can of the re-injury risk. But still, one question we spoke about, the concept was progression of phases based on criteria, but always in the field, the same question, the main question, also the time when the player will be back and how long it will take every phase. So immediately after surgery, the phase of protection of the graft, it will be around 6 and 8 weeks, which we should start it immediately after surgery. Then the strengthening period, it can take 6 to 8 weeks, and it should be start 6 to 8 weeks after surgery. When we go to the re-athletization phase, and the fitness phase period should be between 4 and 6 weeks, and it will be performed 2 or 3 months after surgery. The skill-specific football sports skills take 4 to 6 weeks usually, and it will be 3 or 4 months after surgery, and at least 6 months after surgery we can allow to the player to join the normal training with the group and the competition. Always we think that to put the player in the safe side and to avoid the risk of re-injury, always it should be at least 6 months after the date of surgery. So in athletes, we have to know that there is no consensus of return to sport after ACL reconstruction. There is many protocols, and the main idea is to have the protocol. It's a progression of many successive phases from surgery to return to sport. Based it's around 11 criteria and sub-group medical criteria, performance criteria, and finally sports criteria. Return to sports is highly specific to each athlete. There is individualization of the program for each athlete. This is what we learned from our experience in this field of return to sport. And always the team doctor, the team physician, he needs to be really very ready for the pressure of the, first of all, the player himself. He put always a lot of pressure when he will be back every time, and he's trying always to make sure every phase of the progression of the re-athletization mainly. There is always the pressure coming from coaches, from the management, from the media, and always the same question. Every day we are facing the same question: when he will be back, when he will be back. So we have to know exactly what it means, the return to sport. It is the return to normal training with the group. It is the return to the competition. It is to the return to the pre-injury level. And finally, we have to know that it is always very difficult to predict the return to pre-injury level. This is our team of FIFA Medical Center of Excellence. Special thanks to Esther Esteban Garcia, the head of physiotherapy, Philippe Chaumier, the head of rehabilitation, Professor Frederic Chiami, our surgeon, and myself, and thank you so much.
Dr. Ghrairi, thank you very much for your presentation and for sharing your expertise and knowledge with us. We would love, of course, to watch the videos you prepare for us and see the work at FIFA Medical Center in Dubai. But unfortunately, we had some unexpected IT issues there. But we really appreciate your efforts to make these videos available to us. Now, once again, thank you both for sharing your knowledge as well as your experience on these topics. So what I'm going to do now is let our participants know once more that questions can be submitted in writing by using the Q&A feature. So you can find this on the bottom part of your screen through this Zoom platform. Before, let me check if we've got any questions so far. Yes, we've got the first question from Marie. So the question is, were the rehab or return to play protocols discussed in the Sports Health article in regard to all kinds of anterior cruciate ligament repair surgeries? Was there any discussion whether hamstring grafts versus patellar tendon versus cadaver grafts were preferred for high-level athletes? This is the first question from Marie. I think it goes to more towards Dr. Ghrairi about the...
Say again, please. Sorry, I couldn't hear it properly.
Yes, so the question is, were the RTP protocols discussed in the Sports Health article in regards to all kinds of ACLR surgeries? This is the first question. And the sub-question is, was there any discussion whether hamstring grafts versus patellar tendon versus cadaver grafts were preferred for high-level athletes?
The first question, definitely, when it comes to the graft itself, there is, especially in the protection after month after surgery, definitely there is a slight difference. For example, when it is the patellar tendon graft or hamstring graft, mainly, especially in terms of range of motion, we have to be more careful when it comes to the patellar tendon and the one is
some issues there again.
Start the contraction of the hamstring. After that, it will be. After that, it will be the same protocol, roughly the same protocol. And the second question, the question of the choice, the graft choice, if I could understand that in high-level athletes. So honestly, the graft choice is always a question, but it depends. It depends. I cannot say that there is a special graft with such. It's better to go with other than hamstring. It depends on the knee itself, the biomechanic of the knee, the experience of the surgeon, and also what some players they prefer. Because today I can say when I start my job near 25 years ago, the player cannot come to the surgeon or to the doctor and to discuss with him all the techniques of the reconstruction. Now the player, he come with his agent, with his physio, and we spend like 2 hours to discuss with the surgeon, especially when he's a high-level player. I know one player, for example, he got his injury in China, and he went to Paris to a specific doctor because he's convinced with that technique. So he had the graft as requested by himself, because now really we can see that the players now, they understand, especially the high-level professional players, they understand almost everything. So I cannot say that there is special graft for that graft is better for that player or for that injured player, or that graft is better for that sports. I don't know if it's clear what I'm saying now.
Yep, thank you, Dr. Ghrairi. The second question is more about how much time does it take to full maturation of semitendinosus graft? This is the second question that we've got from JSIC.
So minimum 6 months. Minimum 6 months.
All right, good. So
I know that some cases they can come. I know that some cases they can come earlier. I mean, around 5 months. But I would like to stay always careful, because the big problem is the re-injury. If we go earlier, definitely we will face a higher risk of re-injury.
Good.
Or failure of surgery, I mean.
Thank you, Dr. Ghrairi. One question I would like first, before we move on with the other questions to Dr. Malliaropoulos, is more about the MRI scan and the imaging findings that you discussed in your presentations. So after, let's say, a hamstring injury, and you discussed about the diagnosis, when we move towards the, let's say, return to play, or to actually assess the injury itself, or what happens with the scar tissue, of course, it's not part, and it shouldn't be part of the return to play criterion, of course, but what do you think would be the best imaging, let's say, tool to assess the scar tissue or the development of the injury back to the normal tissue? That would be an MRI scan, or the ultrasound would be the best solution for that?
Well, it depends. It depends on the environment that you are. So, if you are in elite football professional club, definitely every injury will be MRI. To my experience, the assessment must be always clinical, because that's the best and useful tool in terms of everyday following up, or every week following up. You cannot have MRIs every week. So the assessment must be always clinical. So depending on the severity of the injury, depending on the clinical classification. So if you are grade 1 injury in clinical terms, usually an MRI scan is not needed. Or if you have an MRI scan, then you might have no findings or some edema in the area. In this respect, the ultrasound scan is absolutely better, because in real time you have the clinical assessment and the assessment. So for grade 1 and grade 2 injuries, based on the clinical classification, I'm always using an ultrasound scan. For more severe injuries, and you can diagnose them very early on, assessing the active range of motion for grade 3 and grade 4 injuries. Absolutely, you need an MRI scan. So in terms of scar tissue depends on the individual, depends on the severity of the injury, and depends on the treatment. So grade 1 injuries or grade 2 injuries, it's less likely to develop scar tissue. Grade 3 and grade 4, we must always be very careful that they can develop scar tissue after the injury, and we have to minimize that. Re-injuries, it's of a greater risk to develop scar tissue. So it all depends on the clinical assessment and history. How you assess scar tissue, both with MRI scan and ultrasound. So I think the best tool to assess scar tissue is a high-resolution ultrasound scan.
Good, thank you. Dr. Malliaropoulos, thank you for your answer. Now moving to the other questions, we've got a few questions now we need to go through from the participants. Another question from Rob is, why do you think are the main reasons for males being more at risk of hamstring injuries?
I think because of more speed or more acceleration in their sprinting activities. And because, football is more widespread in males than in females. That's the main reason, I think.
Good, thank you, Dr. Malliaropoulos. Moving to the another question: did the Nordic hamstring focus mainly on the lateral or medial compartment of the thigh?
That's a very good question. So we are moving to rehabilitation, and I think that I propose we must have a webinar on muscle injuries or hamstring injuries rehabilitation, because that's a huge topic. So we did a study assessing the activation of 10 different hamstring exercises. So we can group the exercises depending on the intensity, low intensity activation hamstring exercises, medium intensity activation hamstring exercises, and high intensity activation exercises. So hamstrings, so Nordics, it's a high activation hamstring exercise. And we always are using Nordics for the late stages of rehabilitation. Remember from the previous presentation that I mentioned that hamstring group is acting as hip extensors and knee flexors. So going to Nordics, having in mind the Nordic movement, it only involves knee movement, not hip. So Nordics is a part of rehabilitation. It's not the rehabilitation.
Good. Thank you, Dr. Malliaropoulos. Next question is from Charmy, and the question is: can we follow the same grading system for the quadriceps injuries?
That's another great question. So it was a big discussion, especially with a very close friend, Dr. Otto Chan, that he said that we must need a generic muscle classification. And the Munich classification came with a generic one. That's, to me, that's my point of view. That's absolutely unuseful, because quadriceps, gastro, hamstrings, totally different. How we can apply the same size, one size fits all, to every muscle group? We know as a clinicians that the main groups that they are injured are hamstrings, quadriceps, calf. We can apply the same principles that we did for hamstring injuries to those muscle groups, and I think that we will come up with a very useful clinical classification for those groups, and this is a forward future research.
Good. Thank you, Malliaropoulos. Thank you so much. One question for Dr. Ghrairi, and this is more about the actual the whole presentation, actually, the whole work that you do there at the FIFA Medical Center. You mentioned that lately and recently the athletes actually have discussion with the clinicians or the orthopedic surgeons to what will be the graft, and that was not the case before. So based on this experience, Dr. Ghrairi, I would like to ask you, what is based on your experience and all these years that you've been working there, what is the biggest challenge you've got with athletes in general undertaking return to play, let's say, when they go towards the return to play or when they go through the treatment rehabilitation? Is it a lack of adherence to the program? Is it other discussions. So what do you think is the biggest challenge?
Usually when you work with high-level athletes, professional athletes, the big challenge, it doesn't come from the athlete or from the knee itself. It comes always from what is around the athlete. I mean the environment, the coaches, and the management. And technically, it's really very rare. We couldn't face major challenges. Sometimes see only with the we are facing sometimes lack of extension from the beginning. The first, always during this protection phase, I mean post-operative, immediately post-operative, we are facing a lack of extension, despite the fact that always we advise our players or our athletes before going to the surgery. We think that the pre-surgery rehabilitation, it's a major part of the program. We allow always, or we advise always, to go for surgery at least when we have at least three main points. The first, the full extension, this is mandatory. The motion as much as we can, I mean the flexion, especially free of pain, range of motion free of pain. This is the second point. And the third point, with the minimum of power of the quadriceps and mainly the vastus medialis. If it takes roughly 3 weeks, more or less, for surgery. I know that athletes, they are in hurry. Some surgeons also, they prefer to go immediately for surgery. But my advice is to have a good knee well prepared before surgery. Like this, we will go with a normal time frame without many changes after surgery. Sometimes we saw some surgery failures when the player went to the surgery immediately with lack of extension. Obviously, surgery is like a locking knee with major meniscus injury, then it's a kind of emergency. We have to go for surgery. Otherwise, if there is an isolated ACL rupture with a more or less minor meniscus injury, it's my opinion, it's better to advise the player to undergo pre-surgery rehabilitation. Also, in our center, we deal with many surgeons around the world. We have our own surgeons in Dubai and many surgeons around the world. And we deal with many techniques. So after the main techniques, so hamstring reconstruction, graft, and Macintosh, iliotibial bundle reconstruction. And as I said previously, we have to be careful. We have to take into consideration the technique, the surgical technique, basically during the surgery.
Thank you, Dr. Ghrairi. We had some connection. The connection was breaking up a bit, but overall, we heard your answer into this question. Jacek now answer questions. Actually, what do you think about full? Actually, yeah, the full down is deep squats. What do you think about deep squats with weights for hamstring rehab? I think that goes towards Dr. Malliaropoulos more.
Well, I think squats, it's a more complex exercise, activating both hamstrings and the quadriceps. Definitely, it is a good exercise, and I will really recommend it. Yeah, but again, depending on the sport. So always we have to take into consideration to tailor the rehabilitation to be sports specific. So sports can be part of our rehabilitation program, absolutely. But I will add it to the end stage of rehabilitation.
Good, thank you. Thank you both. Thank you, Dr. Malliaropoulos and Dr. Ghrairi. I think it looks like with that we have no more comments. And I think that the questions in particular have been excellent and really engaging. So thank you very much for sticking to cover all of those, Dr. Malliaropoulos and Dr. Ghrairi. And the presentations have been wonderful, okay, and really, really informative as well. So thank you for joining us and contributing to the World Federation of Athletic Training and Therapy International webinar today. At this point, I'm going to invite Glenn Bergeron, the president of the World Federation of Athletic Training and Therapy, to conclude this webinar session. Glenn.
Thank you so much.
Well, thank you very much, and what a wonderful presentation that you all gave. Gave us some really good food for thought and gave us some groundbreaking and state-of-the-art information. I really appreciated that. I think it's something that's so applied to all of us. I see that we have over 140 people that are registered and or participated at one time or another in the presentation. And so I think, and I looked across some of the names, and at least some of the ones that I was able to recognize. This is a global representation. So I want to thank you all for having presented, and I want to thank all of our attendees. This is a wonderful opportunity for us to really connect internationally and to bring the vision and the mission of the World Federation together. And I applaud all of the people who participated, and I know that you will be getting an evaluation form at the end of all of this. If you would take just a few moments to do that, because it just gives us better ideas in terms of the kinds of webinars that we want to do in the future. And again, I want to thank Stavros. This is Stavros' second presentation and webinar in a row that he's organized. These are not that easy to do, but he's done a wonderful job, and he's also taken on the role as being the facilitator of the whole event. And I thought you did a great job. And I also want to be able to thank Oliver Coburn with the BASRAT. And BASRAT and particularly Oliver have been so good about supporting the World Federation in terms of the logistics of putting this together with using their platform and their registration procedures. And Oliver's got work to do after all this is done by sending out the questionnaires and the evaluations and the certificates. So I want to, it's a huge task to put these on, but it is so rewarding for us, and it really, really goes a long way for us promoting the World Federation and our mission and our vision of being integrated in the healthcare team worldwide. Thank you.
Thank you. Thank you.
Thank you. Thank you, Glenn.